Now I invite Dr. Piyush Kapoor to give his talk on when the things don't go the way you want, the Lasik flap related complications.
So my talk has been previously discussed by Dr. Prateek about the microkeratomes, and I would just brief talk about the failures which we can encounter with the microkeratomes. So in the conventional studies which showed that the failure rates with microkeratome was very low, as low as about a 0.3%, but still failure is a failure even if it is 1 out of million. So in our experience, going down straight to the issues which we encountered were epithelial defects, neovascular bleeding from the flaps, thin flaps, free cuts, incomplete flaps, tone irregular ones, decentered ones, striae which occurred in the late post-operative course, and never ever we encountered corneal perforations, though these have been described in the literature. When we talk about free flaps, they are generally because of the malfunctioning which may be seen in the extreme corneas, either the very flat ones or the very steep ones with the small size, the small white to white dia. And the management is never panic about it, carefully replace the flap, and always be sure that you are placing the right side at the right direction and place a BCL after drawing the flap. So this was one of the case of a very flat cornea, 18-year-old male. It had a large diameter and a flat K. We took a 0 with 8 with an SBK. And this is how the picture shows the flap came out. The flap was well placed at this edge and carefully handled. After doing the correct ablation, the flap was comfortably reposited, and it is always better to make your markings on the cornea so that ever if you encounter any such complication, you can place the flap at the right position where it has to be. So the surgery was completed successfully and the patient got a very good vision. So incomplete flaps may occur because of the patient movement or because of the microkeratome failure which may stop before it has to be. So this is a picture you can see where the cut is even less than half of the desired one. So in these cases, this was the second case where the patient actually moved and the flap just flipped off and the lower tone edges were seen. So whenever we encounter such irregular flaps, we need to analyze that what is the zone we need to treat, whether we are getting the right correct stroma to ablate. If at all we are getting the right stroma, we can just reduce the treatment zone from say about a 6 to a 5.5, and if we are able to complete it in that zone, go ahead with the procedure and reposit the flap back. But at the same time, if you get that the flap is very small and you don't get the right edges or the right stromal bed to go ahead, it is better to reposit, abort the procedure, place a BCL, and later you can comfortably plan a surface ablation over this, or maybe take a cut deeper than the plane you have already attained. The next is which you may encounter a buttonhole, which generally occurs in very steep corneas when the cornea does not get properly ablated and it tends to sink down. So this is what it actually looks like. You can see the edge in the center, or you can see in these patients where you get a central island in these. So these are the cases where I would say never ever proceed with your surgery. It will always give you a very irregular ablation and the patient will get a very, very, very unsatisfied vision. So it is better abort the procedure, again reposit the flap in a proper way, and then maybe plan a thick flap at a deeper plane, or you can go ahead with a surface ablation in these cases. Bleeding becomes a common issue when we are dealing with very small corneas and the flap goes almost to the edge of the limbus. So these becomes very difficult to handle, and sometimes it can be so messy that you hardly get a zone which is free from the heme to actually ablate the corneas. It is better to be patient in these cases, place a sponge around the edges of the limbus, or you can take the head of the microkeratome and place it at the edge of the cornea and press it hard so that the surface gets pressed and there is no bleeding as such occurring. And at all, you can even use a phenylephrine dipped sponge to apply and just blanch the vessels around. But you need to be careful. Once I did this procedure of applying a phenylephrine sponge and the pupil just tends to dilate. If you are not very prompt and very fast in this, you can actually get a dilated pupil, which may again, just irregularize your ablation, or the pupil centration may not be possible in these cases. So your attempt has to be fast and prompt. The bleeding has to be controlled with the compression, or if you are using phenylephrine, the ablation has to be done very soon. Of course, the patients come with all sorts of, most of the patients who want LASIK have all decked up eyes, and they come with all the makeup so that they feel that the doctor sees the eyes beautifully. And this is what you can actually see, the debris in the interface. Again, these are the debris which you just need to wash out carefully, and generally instruct your assistant to better clean the eyes thoroughly before taking them up for the surgery. So best way to avoid complication is your experience. And whenever we take extreme cases, when we are using SBKs, we tend to take a stop less than what is recommended by the nomogram. Like when we are dealing with a very small cornea, instead of going in with a ring of 2, with a stop size of 7.5, I generally prefer taking it as 7. So this is your customization about your LASIK. As you customize your A constant with your IOLs, we customize our stops with the experience we gain out of our microkeratomes. But still, after doing the best of the surgery, you can of course encounter late complications. And this was one of the case who came that he said that he was having a lot of itching in the post-operative course. He rubbed his eyes so vigorously that the entire flap was lying on the conjunctiva and the stroma was absolutely exposed. So these are the cases you need to reposit the flap, but if you are doing it just blindly, you may have a epithelial ingrowth coming in these cases in the post-operative times. So while repositing the flap, you need to be very careful of cleaning the stroma thoroughly, even applying a MMC over it, and then repositing your flap. So you get a clean cut cornea like this. Flap striae, as has been discussed by Dr. Prateek, is another complication which we see mostly in very thin flaps or very deep ablations, like doing higher pars. So stretch the flap smooth, place it in a comfortable way, but still, all said and done, when the patient comes late and he has epithelialization along the striae, it is always better to go ahead, just remove the epithelium while removing the striae, because until you remove the epithelium, you will not be able to get a flap reposited back into its normal position and the striae may persist. So removing epithelium while cleaning the striae or removing the striae is the main key to a successful reposition. Epithelial ingrowth, again, we commonly encounter in re-ablation cases. It is easily handled by just rewashing the flap again or using a YAG laser. DLK, which is a sterile inflammatory condition, can of course be treated with steroids. And my tips for a successful surgery is always counsel the patient thoroughly, check your blade and machine assembly properly, take the proper size of the stop and the ring, and decide your own ablation, how you have to plan it. Thank you.